We are live. Lavina, you can start.
Yes, sir. Good evening, everyone. Welcome to the Higgs Journal Club for the month of June. I'm glad to welcome Jose Chaco sir, Gansham sir, Srinivas sir, and we have Dr. Jignesh Shah joining us. He's the professor at Bharati Vidyapeeth Pune, and Dr. Manoj Raju, who is going to take us through this trial, Enrich Trial, the trial about the early minimally invasive evacuation of the intracerebral hemorrhage. Over to you, Manoj.
Good evening, everyone. Thank you, Srinivas sir, Gansham sir, for giving me this opportunity. Uh, Today's journal is Trial of Early Minimal Invasive Removal of Intracerebral Hemorrhage. This is recently published in April 2024 in NEJM. We'll go through this trial with clinical question, review of background information on the topic, and appraisal of this trial as per JAMA user guide. Clinical question, that is whether early minimal invasive surgical removal of ICH would result in better outcomes than medical management. Coming to the background information, as per ASA AHA 2022 ICH guidelines, minimal invasive surgery evacuation, the class of recommendation is 2A, that is benefit more than risk. For the patients with supratentorial ICH of 20 to 30 ml with GCS of 5 to 12, minimal invasive hematoma evacuation with endoscopic or stereotactic aspiration with or without thrombolytic use can be useful to reduce the mortality compared with medical management alone. And for same use of minimal invasive surgery can be considered over conventional craniotomy to improve the functional outcomes. And when we use minimal invasive surgery for hematoma evacuation, the effectiveness of its use to improve functional outcome is uncertain. The last two class of recommendations were 2B, that is benefit more than or equal to risk. The level of evidence is BR, that is moderate evidence. Coming to the craniotomy for supratentorial ICH, craniotomy for supratentorial ICH, the class of recommendation is 2B. That is for most patients with spontaneous supratentorial ICH of moderate or greater severity, the usefulness of craniotomy for hemorrhage evacuation to improve functional outcomes or mortality is uncertain, and craniotomy has to be considered as a life-saving measure. The class of recommendation is 2B recommendation. Coming to the evidence for craniotomy, we have Stitch 1 trial and Stitch 2 trial. Stitch 1 trial, that is surgical treatment for intracranial hemorrhage, which came in 2005 in Lancet. They compared early surgery, hematoma evacuation within 24 hours of randomization with medical management compared with initial conservative management. They found no benefit from early surgery. Stage 2 trial came in 2022. They included patients of 10 to 100 ml of intracranial hemorrhage, not due to vascular malformation or tumor, and bleeds less than or equal to 1 centimeter from cortex with GCS of more than or equal to 8, no IVH, less than 48 hours from ictus. They compared early surgery, that is within 12 hours, with medical treatment or initial conservative treatment. They found no significant difference in extended Glasgow outcome scale at 6 months, and they found survival advantage in intracerebral hemorrhage without IVH with craniotomy. Coming to the randomized controlled trials comparing the minimal invasive surgery with medical management or conventional craniotomy, there are around 12 RCTs which has been published. First RCT came in 1989 with Orr et al., which had shown mortality benefit at 180 days. To the recent most, that is minimal invasive surgery plus recombinant tissue plasminogen activator for ICH evacuation. This is a phase 3 trial, that is MYSTIC, came in 2019. They included ICH of 30 ml or more from initial CT with GCS of 14 or less and modified Rankin scale of 0 or 1. They randomized 255 to MYSTIC versus 251 to standard medical care they found mortality benefit that is 19% versus 26% at 365 days. This is followed by a recent meta-analysis which included 12 RCTs, one cohort study. This is the forest plot showing the minimal invasive surgery and the control groups for overall mortality. When we observe this, all the studies favor minimal invasive surgery. Coming to the summary of meta-analysis, there are around 8 meta-analyses which has been published on comparing the minimal invasive surgery either with the craniotomy or the conventional treatment. Almost all meta-analyses shown that minimal invasive surgery is better. Coming to the Enrich population, they included adults 18 to 80 years, CT demonstrating acute spontaneous primary ICH, volume between 30 to 80 ml, GCS of 5 to 14, NIHS of more than 5, modified Rankin scale of 0 or 1 before the occurrence of the hemorrhage. Intervention, they use minimal invasive surgical removal within 24 hours of hematoma using the NIPO device plus guideline-based medical management. That is the surgery group comparing with guideline-based medical management alone. Outcome, they measured utility-weighted modified Rankin scale at 180 days. The study design is randomized controlled trial. Coming to the inclusion criteria, all patients of 18 to 80 years were included, demonstrating CT demonstrating spontaneous primary ICH volume between 30 to 80 ml. They calculated by ABC by 2 method, and anatomical location of lobar and anterior basal ganglia ICH were included. Study interventions reasonably to be initiated within 24 hours of onset of stroke symptoms. If the onset is unclear, then the onset will be considered the time that the subject was last known to be well. Coming to the exclusion criteria, they excluded any patients with ruptured aneurysm, AV malformations, vascular anomaly, moya disease, venous sinus thrombosis, mass or tumor, or any recurrence of recent ICH less than 1 year, NHS of less than 5, bilateral fixed pupils, extensor motor posturing, any IVH, visually estimated to involve more than 50% of either of the lateral ventricles. If it involves primary thalamic or inferior infratentorial ICH were excluded. Any uncorrectable coagulopathy or known clotting disorders are also excluded. Other exclusion criteria were routine, which are used. Coming to the intervention, is called small craniotomy and a durotomy to the sulcus, and the trajectory to the hematoma was planned with the use of image guidance. They called it as transsulcal parafascicular surgery. The hematoma was accessed by brain path minimal access port, which is shown in the figure A, that allowed a bimanual technique with visualization, and the hematoma was evacuated with suction and the myriad device, which is shown in the B. These both the devices are FDA cleavage devices which are manufactured by Nico. After hemostasis, bone flaps were repositioned, secured, and closed. Following this, all the patients in this group were received standard medical management. Crossovers are strictly prohibited. Coming to the control group, that is medical management, they followed the routine standard medical management for any patients with raised ICP. That is blood pressure control of less than 180. If more than 250, target reduction of 25% in 6 hours. Targeting INR of less than 1.3. Platelet counts should be more than 75,000. If hemoglobin is less than 7, transfusion is triggered. Fever is avoided. Seizure prophylaxis in minimal invasive surgeries for 7 days. And routine ICP monitoring. DVT prophylaxis, they consider pneumatic compression device and chemoprophylaxis within 4 days. Glucose management targeting 80 to 180 milligram per deciliter. If IVH is there, CSF diversion, EBD without intrathecal tissue plasminogen activator on subject basis. Decompressive hemicraniectomy, either treatment arm with poor mental status, significant midline shift, large hematomas, or refractory elevation in ICP were considered for hemicraniectomy. Respiratory care targeting PaO2 of more than 60 with PaCO2 of 35 to 45 mm of Hg. tracheostomy considered after 14 days. In nutrition, all patients will undergo dysphagia screening and in nutrition is initiated as soon as possible. Co-interventions, they followed this protocolized medical management was followed and both the groups received same medical management. Coming to the outcomes, outcomes were measured based on the utility weighted modified Rankin scale, which has 5 attributes, that is mobility, self-care, usual activities, pain or discomfort, anxiety or depression. This is scaled from 0. As it goes to 1, the outcome is better. Coming to the study design, this is a prospective, open label, multi-center, randomized, comparative effectiveness study with endpoint adjudication, which was conducted between December 1, 2016 and August 24, 2022 in USA. Sponsor was Nico, the manufacturer of the devices used in the trial. Trial was conducted in accordance with the International Council for Harmonization, Good Clinical Practice Guidelines, and trial protocol was published and approved by Institutional Review Board at each site. Patients were enrolled after written informed consent was obtained. They had defined 3 adaptive decisions: stop for futility, stop for predicted success, and continue with follow-up. A clinical meaningful effect has been defined, that is a between group difference in the mean score on utility weighted modified Rankin scale of at least 0.075. Missing values, they used multiple imputations in Bayesian primary analysis on the basis of scores collected at 90 days and the treatment group. Statistical analysis were conducted with the use of FACS, Fixed and Adaptive Clinical Trial Simulator version 6.4 or software version 4.3 with the use of STAN package version 2.26. Coming to the sample size calculation. This is an adaptive clinical trial with the sample size between 150 to 300 subjects. This is based on Bayesian primary analysis in simulation had shown 90% or greater power for detecting superiority of surgery over control with a in-between group difference of utility weighted modified Rankin scale in both hemorrhage location of 0.15 or higher with approximate one-sided type 1 error of less than 0.025. Coming to the statistical analysis, they have designated interim analysis at 150, 175, 200, 225, 250, and 275 patients had undergone randomization. They have done an intention to treat analysis. The pre-specified threshold for showing the superiority of surgery plus medical management over medical management alone at 180 days with a posterior probability of superiority of at least 0.975. The groups were compared with the respective score on utility weighted modified Rankin scale. Coming to few things about the Bayesian analysis. Bayesian analysis works on three things: prior distribution, likelihood function, and posterior distribution. Prior distribution is nothing but is beliefs held by researchers about the parameters in a statistical model before seeing the data, and it is expressed as prior distributions, followed by likelihood function, that is the conditional probability distribution of the given parameters of the data, which is defined up to a constant. Based on this prior distribution and the likelihood function, they derive a posterior distribution, that is a way someone summarizes one's updated knowledge, balancing the prior knowledge with the observed data. Coming to the JAMA users guide, we'll go through the results with, are the results valid? What are the results? How can I apply results to the patient care? Are the results valid? Were the patients randomized? Randomization is central. Online electronic data capture system is used, stratified according to GCS score of less than 9 or more than or equal to 9. Location of hemorrhage, that is anterior basal ganglia and lobar. Subjects are followed up for 6 months or death. Was randomization concealed? NH stroke scale and modified Rankin scale assessment were performed by certified trial personnel at each site for each patient by means of audio recorded structured interview at 30, 90, and 180 days after randomization. Site personnel were aware of patient's trial group because of the physical evidence. To mask the trial data, third party uploaded the audio recordings and they have removed any identifying information and the group assignment. Neuropsychologists with specialized training and experience in the stroke outcomes reviewed the redacted audio recordings and entered the adjudicated score. This is the conserved diagram showing 11,603 patients were assessed for eligibility, of which 11,303 were excluded. 300 underwent randomization. The reason for exclusion has been mentioned. 150 were assigned to the surgery group and 150 to the control group. Of the surgery group, 48 had anterior basal ganglia ICH and 102 had lobar ICH. In the control group, 44 had anterior basal ganglia and 106 had lobar ICH. In the surgery group, 1 was lost to follow-up and 7 withdrew consent. In control group, 7 were lost to follow-up and 4 withdrew the consent. So in the surgery group, 147 had observed score on modified Rankin scale at 180 days. And in control group, 139 had observed Rankin score at 180 days. So 150 from surgery group and 150 from one control group were included in an intention to treat primary analysis. Were the groups comparable? This is the table showing the demographic and clinical characteristics of the patients at the baseline. When you see the median score was 16 in the surgery group and 18 in the surgery group, which is comparable. Score of the Glasgow Coma Scale less than 9, 25 in surgery group and 29 in the control group, and more than or equal to 9 of 125 in the surgery group and 121 in the control group. And the median hematoma volume is 54 ml in the surgery group compared to 55 ml in the control group. Median ICH score is 2 in both the groups. Score on modified Rankin scale less than 1 before ICH occurred, 29 in surgery group and 17 in the control group. And the median time for randomization from the last well known was 12.8 hours in surgery group to 12.9 hours in the control group. Based on this data, both the groups were comparable. What were the results? Primary efficacy endpoint, that is modified utility, estimated mean utility weighted modified Rankin scale at 180 days. When you see in the surgery group, the score was 0.458. In the control group was 0.374. The estimated difference was 0.084 with a posterior probability of superiority of surgery is 0.987, which is more than the pre-specified threshold for superiority. Coming to the secondary endpoints, when you see ICU length of stay, which is 6.9 plus or minus 6.8 in the surgery group, 9.6 plus or minus 7.6 in the control group, with a credible interval of minus 4.5 to minus 1.1. Hospital length of stay is 14.9 plus or minus 11.2 compared to control group of 18.1 plus or minus 11.9, which is shorter in the surgery group. Hematoma, the score of less than or 3 of modified Rankin scale at 180 days was 74 people in the surgery group compared to 57 in the control group. So more patients had better modified Rankin scale at 180 days. Number of days receiving mechanical ventilation was 5.3 plus or minus 6.3 in the surgery group compared to control group in the control group of 8.8 plus or minus 6.6, which was less in the surgery group. In the surgery group, 5 received required decompressive hemicraniectomy compared to control group, 30 people required head decompressive hemicraniectomy. Volume after completion of surgery, that is less than 15 ml, 109 patients had less than or equal to 15 ml in the surgery group. At the second interim analysis, after 175 patients had been enrolled, a pre-specified futility criterion was met for the anterior basal ganglia location. So enrollment for patients with a hemorrhage in the anterior basal ganglia location was ceased. Coming to the safety endpoints, that is death at 30 days, 14 had death at 30 days in surgery group compared to 27 in the control group. So the estimated difference is minus 8.7 with a posterior probability of superiority of 0.987, which is more than the pre-specified threshold of for superiority. Coming to the serious adverse events, 95 patients had serious adverse events compared to 118 patients in the control group. So the estimated difference was minus 15.3 with a posterior probability of superiority of 0.998, which is more than the pre-specified threshold, which is significant. How can I apply the results to the patient care? Were the study patients similar to my patients? The strict inclusion and exclusion criteria will affect the generalizability. Were all patients important outcome considered? Yes, but utility weighted modified ranking scale has not been validated specifically for this purpose. It is used for the stroke outcomes. Are the likely treatment benefits worth the potential harm and cost? Harm is reported in this trial in the controlled conditions. So availability of and expertise, cost limits the applicability in resource limited settings. Coming to the discussion, functional benefit was observed at 180 days on a utility weighted scale of disability. The results in the pooled analysis appear to be attributable to the surgery effect in the lobar hemorrhage location. The generalizability of these results is limited to restricted population meeting the trial entry criteria. Approximately 2/3 of patients in the surgery group had hematoma of volume less than 15 ml after surgery, which is associated with improved outcomes based on the previous studies. No conclusion can be made with respect to the results being specific to the type of surgical technique. Conclusion reported in this trial of minimal invasive surgical evacuation of intracerebral hemorrhage of 30 to 80 ml within 24 hours after onset. Weighted disability scores were better with surgery plus medical management than with medical management alone. The results was apparently attributable to intervention for lobar supratentorial hemorrhages. Strengths, crossovers were strictly prohibited. Each participating center had one neurosurgeon, neurointensivist, who are principal investigators who had experience with surgical technique before the trial began. Modified ranking scale at 30, 90, and 180 days were audio recorded based on a structured interview. NHS was performed by a certified personnel. Third party uploaded the data for final assessment of the outcomes. The method used for calculation of hematoma volume, initially they used ABC by 2 method, followed they are given to a neuroradiologist. The treatment of every patient was reviewed and monitored by the leadership team. The surgeries were video recorded. The first 2 cases at each site were reviewed by the leadership team to ensure consistency with the surgical manual. Few points about the sponsors. The purchases related to surgery were done unrelated to the trial participation. The sponsor did not participate in the providing devices for free or at reduced cost. Data collection, they are not involved in data collection or data analysis. They did not contribute to trial design. They did not contribute to scientific concepts or decision to submit the manuscript for publication. There are no confidentiality agreements were made between the investigator and the sponsor. Limitations. This is an open label trial and excluded patients with hematoma volume less than 30 ml or more than 80 ml. Recruitment of patients with basal ganglia hemorrhage was halted for futility. The utility weighted scale used as primary endpoint has been used in ischemic stroke trials that included some patients with intracerebral hemorrhage but has not been validated specifically for this purpose. Bayesian analysis have the potential to be over influenced by the pre-specified prior distributions. However, in the sensitivity analysis of prior distribution suggested that the results of the primary analysis were consistent with the choice of reasonable alternative prior distribution. These are the upcoming trials which will give us few inputs into this concept. One is INVEST, which is an ongoing trial, minimal invasive endoscopic surgery with Apollo in patients with brain hemorrhage. Another one is MIND, that is minimal invasive hematoma evacuation with Artemis neuro evacuation device. This is going on in Germany and USA. Dutch intracerebral hemorrhage surgery trial, which is going on in Netherlands. Minimal invasive intracerebral hemorrhage evacuation mirror, which is going on in USA, and evacuate trial, which is going on in Australia, which will give more inputs into this trial. Thank you, sir.
Thank you, Dr. Manoj, for the wonderful presentation. Dr. Jignesh Shah, sir, I would like to take your comments on this article.
Thank you, Manoj. Thank you,
Thank you.
Hicks, for providing this activity. So basically, as presented by Manoj, it's a very well conducted trial, very well planned conducted trial in US across 37 centers. And the difference here is in comparison to the classical frequentist method of sample size calculation and looking at the results. They've used the Bayesian method, which is most commonly used nowadays in all stroke studies. So there's a difference in the approach, yeah? But this Bayesian is based on a computation model, which takes into consideration the probability, the biological probability, in addition to the observations. And all this will help you to define the three specific criteria for significance. So the one important thing is, like, traditionally we've been saying that any bleed of more than 50 cc's is having a poor prognosis, and usually we don't intervene unless they are very superficial or cortical. This study included wide range of patients, right from 30 cc to 80 cc. They have taken many elderly patients up to age of 80. The technique was very well defined, and the
Conflict of interest. Jignesh, please carry on.
hello.
Yes, sir.
Jignesh, please continue. Please continue.
Yeah. Okay. I thought I got disconnected. So about this, coming back to the inclusion criteria. So normally what we see predominantly the appendicitis bleed locations are thalamic locations, and they've excluded those because deep-seated bleeds are difficult to evacuate. So that may be the major the issue with most of the patients. The cortical bleeds, they're easy to evacuate. Coming back to the results, so normally MRS is being taken as a result for most of the trials related to neurological interventions. It is very well validated tool, and usually it's a binomial thing. So anything less than 3 to 4 is the cutoff, which is less is better, and anything 5, 6 is worse. Here they have tried to change this MRS to something called as utility weight scores, where they have tried to give particular individual weights to particular activities of MRS. So anything which is 5 and 6 is going to be grossly dependency, and that's why they have given 0 score to the utility weight score. MRS score is 0 for MRS of 5 and 6. This utility weight MRS has been used for stroke patients, but for bleed it was first of a kind thing. And if you look at this, I think it is practical to look at utility weight MRS. Coming to blinding, it was not possible because it was an open label and you can't blind a surgical intervention or technique. They have taken enough safeguards in that context. There was an allocation concealment after randomization. Those people who are evaluating MRS at 30, 60, 90 through a video interview or direct patient interview, they basically have tried to have a independent person doing those interviews. And if even if the patient discloses that he had a surgery, they've tried to remove that portion of the interview and then independently upload it for a neuropsychiatrist to review those interviews for MRS. So they've done enough safeguards to have a proper evaluation of the endpoint in form of utility weight MRS. Um, so the only difference is we'll have to all be familiar with this Bayesian analysis from this trial. Um, Over to you, sir.
Joe, sir, your comments on this?
Yeah, thank you, Navina. So this trial, the Enrich trial, is a very important trial because the main reason being in intracranial hemorrhage, intracerebral hemorrhage, we do not have much to offer the patient. Most of them have very large bleeds and they are left with considerable deficits for which we can do nothing specific. Take, for instance, thrombotic stroke. We have several treatment modalities available these days, including thrombolysis, including mechanical thrombectomy. And as a last resort, you do decompressive craniectomy as well. And the outcome is generally much better than severe intracerebral hemorrhage. So given that background, and also if you consider the previous STITCH 2 trial, which showed that conventional surgical evacuation of intracerebral hematomas do not improve clinical outcomes. So against this background, we can at least now say that we have a clinical study that showed improvement in outcomes with a minimally invasive approach in intracerebral hemorrhage. This is the first randomized controlled trial to definitely show favorable clinical outcomes. So that way, it is a very important trial. The methodology of the trial, of course, is slightly different, but in tune with most of the current studies. They used a adaptive randomization design, like the REMAP-CAP trial. So many of the newer trials do that. Adaptive randomization means instead of doing interim analysis at different stages, you look at the outcomes and alter the design of the study in such a way that you get maximal benefit. So in this case, after the enrollment of the first 175 patients, I think, they excluded patients with anterior basal ganglionic bleed, who did not seem to benefit. So that was a positive benefit of using a adaptive design in this particular trial. And they used the Bayesian approach, which is based on the prior knowledge, and there is a modification based on your observations to get a posterior probability. So compared to the frequentist technique, especially in treatment modalities that you are not very clear about the results, you're not very clear about the outcomes, using a Bayesian technique is probably much more valid than go by the frequentist method and be a slave to the p-value of 0.05 as we used to do in most of the studies previously. So it's a pretty good groundbreaking study, I would say, that suggested benefit with a minimally invasive parafascicular cranial surgery. And there are many more studies that are coming in the future, including the MIND trial, the INVEST trial, the MIRROR trial, and so on. We're using different devices. This particular device was the NICO Myriad device. There are many other devices that are being experimented upon. In fact, we do not do minimally invasive evacuation of intracerebral hematomas in our unit. Very occasionally, they use the open approach, but that depends on the individual surgical preference of these surgical consultant involved, and also the baseline clinical condition of the patient, the size of the hematoma as well. So, but that technique, we do not have any evidence to support an open technique. So with this particular study, hopefully we have found a new strategy of tackling intracerebral hemorrhages. There are some limitations to this trial, of course. First and foremost is that blinding was not possible due to practical reasons. Anybody could make out who had open surgery, who did not have. So that obviously cannot be avoided, but it may have caused bias among the investigators, knowing which arm the patient belonged to. And as I mentioned, you cannot take this trial as a validation of all locations of hemorrhage. Anterior basal ganglionic bleed may not benefit. The assessment was by telephonic interview, which may not be ideal. A physical evaluation may have been more robust. And also, last but not the least, if you look at the number of patients they evaluated initially, it was 11,600. They excluded 11,300 patients, leaving them with just 300. So it's a highly selected subgroup of patients with intracerebral hemorrhage. So that's something you need to bear in mind in the real world. You would need to be very judicious when you choose whom would I subject to this procedure or not. But having said that, it's an important trial which might turn out to be an important milestone in the management of intracerebral hematomas.
Thank you, sir. I think its generalizability to the patients that we see in the ICUs is probably not as good as it's supposed to be because it's very selective, like sir said. I don't know if any centers are doing it, sir. Are there any centers doing it, sir?
Not to my knowledge.
Not, yeah. Especially if this device is just picked out its availability. So I think it's not available.
Okay.
Kancham, sir.
Okay. See, I think the whole idea of evacuating the hematoma is basically looking at three key principles. One, to decrease the ICP. Evacuating the hematoma decreases the ICP drastically, and then preventing your hematoma expansion. And thirdly is to prevent the secondary inflammatory injury, which is very common in patients who have large IC bleeds. So there is a strong physiological rationale, and as Joseph said, compared to a stroke patient where we have many interventions and treatment options available, for patients with intracranial hemorrhages, the options are much lesser. So, as I said, there is a strong physiological rationale, and if you look at both the Stitch 1 and Stitch 2 trial as well, sir, correct me if I'm wrong. I think the outcomes were better with the surgical evaluation, though they did not reach statistical significance. They were marginally better.
I think mortality was
They
better.
have looked at mortality outcomes, not
Mortality
the
was
functional
better.
outcomes.
But,
But it was not
statistically significant.
I think
what people consider as an acceptable outcome in general, of course, it varies depending on your culture, etc. But generally speaking, an MRS of 3 or lower is considered to be good. 3 is the ability to walk without assistance. So that is something that is considered positive. So I think the Stitch 2 trial did not show improvement as in number of patients with a modified Rankin score of 3 or less with the open method.
So I think the major reason with both Stitch 1 and Stitch 2 was because it was open. They also had to do some amount of lobectomy of the healthy brain tissue. I mean, when they had to cut open, and that could have been one of the major reasons why the neurological outcomes were not good. Subsequently, the Misty trial also had shown mortality benefit with a minimally invasive device. So yes, there seems to be a good role for minimally invasive device for evacuation, but I think it is going to be useful only in a very highly selected group of patients with lobar hemorrhages. In the current day scenario, we see a lot of patients who are on anticoagulants and antiplatelets. There is a good number of patients who come with intracranial hemorrhages on a background of either anticoagulation use or antiplatelet use. I think they were one of the major exclusion criteria. So whether this will be applicable to them or not, but again, if you go with the same rationale, probably correction of the coagulopathy with evacuation in patients who have lobar hemorrhage does make sense. We do once in a while, we have the minimally invasive technique available, but I'm not sure which device they are using it.
How are the results, sir, in the patients that you have seen?
See, until unless you actually do a very a proper analysis, you're always biased, thinking that those patients where you have done the intervention, they have done well.
Agree.
And it's important that all these trials should look at the functional outcomes, not the mortality, because we've had studies in trauma, decompressive anatomy. There was a mortality benefit, but the functional outcomes were very poor. So in our Indian context, probably we'll have to focus more on functional recovery, functional outcomes, rather than mortality as an outcome.
Yes, mortal, being alive, but severely disabled, needing continuous bedside assistance for all activities of daily living is not a worthwhile life to most people, but of course, opinions may vary.
Srinivas, your comments on this?
Yeah, I think this is a highly exclusive group of patients who are treated. It has a huge outlier effect. Practically applicable practical applicability to a wide cohort of IC bleed patients may not be feasible. But keeping that aside, uh, there is at least some hope for the patients with IC bleeds. Ischemic stroke, now up to almost 24 hours, we have options. We can do something to salvage the salvageable penumbra in ischemic stroke patients. We did not have much options for patients with IC bleed. This is probably the beginning. Just like we started with thrombolysis for 3 hours and then extended to 4.5 hours, slowly over the last 10 years, this window has extended up to 24 hours. So maybe in next 3-4 years, the applicability of this study to a wider number of patients would increase. But I think this is definitely a game changer, or it is probably a practice changing study for those patients who fit into the inclusion criteria, at least for the time being. But going forward, more patients may benefit from this approach, is what I feel.
Thank you, sir. Are there any exclusive centers that they are doing this in India, particularly?
I don't know. With this technique, with this hardware, with this inclusion criteria, I don't think anybody is doing. But as Ghanshyam said, some of the neuro specific or neuro centered hospitals have minimally invasive techniques for bleeds, and it should not be difficult to modify this technique and adapt it to our setting. In these hospitals, but I don't think we don't have a registry. First of all, that's been the biggest problem in data that comes from India. We don't have data. People don't collect it. People don't report it. So we can't say that it is not being done because we don't know. So all I can say is I don't know whether it's being done in India or not.
Okay. So it looks promising, but we don't know the exact group of patients where we can actually do it. And like early, can it just be like within 24 hours as it is taken in this trial, sir?
It has to be early. It has to be early because if at all you have to give the benefit, then it has to be early. Because once it crosses the 24 to 48 hours window, then both the effect of on the intracranial pressure as well as the secondary inflammatory response that it triggers, right? I don't think you will get the benefit if you do it later. See, currently in most of the settings, I'm sure that my fellow panelists would agree. Most of the time, we will look at interventions, surgical interventions in IC bleeds after the patient has spent 24 to 48 hours. When the patient is deteriorating, that's when we actually generally take the patient for surgery. Whatever decompressive craniotomy that we do, predominantly it's either the patient is in a very, very sick condition where he's coning with severe ICP, or there's a tendency for patients to be managed conservatively for the first 24 to 48 hours. And then when the secondary deterioration happens, that's when majority of the patients are taken up for a decompressive craniotomy.
Yes, sir.
Yes.
So in this
Usually
study,
when
they
the
have looked,
TCS deteriorates. Yes, sir?
yeah, in this study, they have also looked at the safety endpoints, the incidence of rebleed, because when you evacuate the clot for an ongoing bleed, there's always a risk of increase in bleed. The other thing is they have also excluded patients with intraventricular extensions. So they
Right.
have excluded patients who have got bleed into lateral ventricles. More than 50% of lateral ventricles are filled up. So this is one of the things which we commonly see. So those bleeds decussating and going into the into the ventricles. And there was no, they have defined bleeds with clinical significance, like drop in GCS of 2 or drop in NHS of 4. And there was no increase in incidence of rebleeds in these patients with this device reported as a safety endpoint.
Yes, sir. Any conclusive comments, sir? Manoj, what is your take on this trial that you have presented to us?
As all said, based on this, selective patients had shown an improved outcome. So it all depends upon which patients were selected for this surgery, and different devices has not been evaluated. So we have to look at which are the devices which will give better outcome in these patients.
And of course, it's important to remember that the manufacturers of the device, they will have to provide sufficient training and expertise to the surgeons involved. That's what they did, I think, with this trial as well.
They did with this trial, sir.
Yes.
They had done
So that's important.
all the centers had training in the use of these devices.
Yes.
And the
So
first two use was monitored by the team,
yes.
the initiators team.
Yeah. Without adequate experience and exposure to this device, or with any device for that matter, there are many devices that are being used now elsewhere in clinical studies. So you need to train the surgeons involved and ensure that they have sufficient skill to do this. And that will take a significant input and expertise from the makers, from manufacturers, even if they don't support it financially.
Are they cost effective, sir? I was just wondering.
I don't know. I don't think anybody has looked at it.
When you are putting patients on ventricular assist device waiting for a transplant in this country, I think saving an IC bleed and restoring somebody to functional independence, I think cannot be measured in terms of any cost.
Agree. Your conclusive comments on this trial, sir?
At least hypothesis generating. I think neurotrauma, neuro care centers, critical care centers specializing in neuro care, stroke care should definitely look at this and try to incorporate this into their IC bleed management protocol wherever feasible.
Thank you, sir. Joe, sir?
Yeah, I think it holds a lot of promise for the future, and it may be the way ahead, I feel, minimally invasive evacuation of intracerebral hematomas, because so far we haven't been able to offer any kind of intervention to improve their clinical outcomes. And this may be an important first step forward. We'll of course have to refine the technique. We will have to make it more inclusive to include more patients. And as we gain experience with more patients, hopefully the outcomes will also improve, as we see with most other interventions.
Ghanshyam sir, I think next time you see a patient, something we would like to share your experience.
Yeah, sure, Navina. I think among a plethora of negative trials that we are used to in intensive care, even though this is extremely selective population, there is some positive outcome that we have seen after a long time. So I think with the kind of technological advancements we are seeing, I'm sure that in coming days, some company would make an innovation which will be more advanced and with lesser trauma to the normal brain tissue. So
As
I think
long
that's
as the
going to have
study is not, as long as the study is not done in Australia, it will be a positive study. The moment an ANZIX group steps in to do a study, it will be a negative study.
That's bias.
No, it's not bias. It is evidence. No ANZIC study is a positive study till today.
Okay, sir. Yeah. Thank you, sir. Thank you, all the panelists. Thank you, Srinivas sir. Thank you, Gansham sir. Thank you, Joe sir, for joining us. A
Thank
special
you.
thanks to Jignesh sir and Dr. Manoj for being a part of this journal club. We will meet next month, and do subscribe to our YouTube channel of Higgs. Thank you.
Thanks.
Thank you very
Thank you,
much.
Manoj.
Have a
Thank you,
good day.
Jignesh.
Bye bye.
Thank you,
Bye.
sir. Thank you,
Bye.
sir. Bye, sir.
Thank you, Manoj. Extremely
Thank-
well presented. Thank
Thank
you,
you, sir.
Jignesh. Good
Thank
to
you,
see you
sir.
after such a long time.
Yes. You're coming for
Okay.
Bob?
हाँ आ रहा हूँ,
अच्छा
but
मिलेंगे.
only for the workshop. ठीक है?
Yeah, we'll meet. Yeah.
Okay,
We'll
चलो,
catch
bye.
up. Hello,
Bye, sir.
Bye, bye.
Bye, sir.